Brilliant. Okay. So good afternoon, good evening, good morning, everyone. Great to have everybody on the call today. So very, very happy to welcome Dr. Andrew Kwiringira, who is the head of the IOA, the Integrated Outbreak Analytics Cell here in Uganda. He's calling in from Jinja today. And today's call is really to give Dr. Andrew an opportunity to talk about how the setup in Uganda has been, some of the successes and challenges in setting up and leading the cell, and where we can support him and where he sees the cell going in future. So he'll present for a little bit, and then we'll also have a chance to have some discussions. We only have the one presentation today, so that we really do have a chance as a group to discuss and to support. Yeah, so Dr. Andrew, over to you.
Thank you, Simone, for that introduction. Good afternoon and good morning, colleagues. I'm Dr. Andrew Kwiringira. I'm a senior epidemiologist at Ministry of Health, Uganda, and I was privileged to be the IOA Cell lead in Uganda during the current Ebola outbreak. So Uganda is highly vulnerable to public health emergencies due to its geographical location next to the Congo Basin epidemic hotspot. And it is placed also within multiple epidemic belts, but we also have a challenge of refugee influx and a high population growth rate. So, for example, at the start of this year, 2022, Uganda was already hosting over 1.5 million refugees, making it one of the most important refugee host countries in the world. Actually, it is the largest in the continent of Africa. Between January 2014 and December 2021, the Public Health Emergency Operations Center was activated for 271 public health emergencies. Because of these recurrent outbreaks, over time, we have established a strong leadership and coordination mechanism from the national and subnational levels. As an example, the Ministry of Health was delegated a responsibility for coordinating response to health-related disasters. And within the Ministry of Health, a technical committee called the National Task Force was established to coordinate emergency response. The NTF is comprised of technical committees, and these include the case management, surveillance, laboratory, social mobilization, logistics, and finally, the strategic information research and innovation, commonly referred to as the CIRI. So within the CIRI pillar, as a subcommittee of the National Task Force, we support other pillars on matters associated with analytics, data management, and digitization. Digitization involves digitizing all the outbreak tools, such as the case management tools, but also managing all the data sets that are related to the outbreak. So despite that kind of organization and coordination, previously we failed to generate real-time analytics that could inform decision-making, mainly because partners who were on board were working in silos rather than having a collaborative, holistic analytics. But also, data collection was not adapted for use. Some deployed inappropriate methodologies, but also they lacked engagement with the data users from onset. So if you do not engage the data users from onset, you have issues them adopting your recommendations. More so, the analytics were done and recommendations were developed, but there was no mechanism in place to track the use of evidence by pillars or other users. So we'll now share the situation on how the IOA worked in Uganda. So during the current Ebola outbreak, the Ministry of Health requested for establishment of IOA because of those previous challenges I've discussed with you. And it was proposed that the IOA is housed within the city pillar, the pillar which was already responsible for data management and analytics. So the Ministry of Health assigned the IOA Cell lead and other IOA support teams from Ministry of Health were also brought on board. We had partners from UNICEF, World Health Organization, US CDC, MSF, Epicenter, London School of Tropical Medicine, Antwerp, and several other partners were brought on board to support the cell. Some were based in the country, but also others supported remotely. So the objective of the IOA were to support response pillars in quality data collection and analytics. This was mainly to address the challenge which I've discussed previously of fragmentation and having several pillars do things in silos. Another objective of setting up the IOA was to oversee, to identify key questions and understand outbreak trends and the impacts of outbreaks, but also the impacts of our interventions, like the lockdown, all the other interventions that we deploy in response. We are also to communicate evidence across response pillars for decision making. But also because previously recommendations had been developed and the users were not able to track the actual implementation of those recommendations, the objective of the cell or IOA was to monitor use of evidence by pillars and several other actors. So how did we operate? So everything came from a trigger question. And these questions were coming from our classical epidemiological data. We look at the situation reports daily. Then you ask ourselves, why are we observing what we are observing? But also we had the requests that we are coming in from other pillars. A pillar could have a specific question that they want us to answer, and we will take it on board. But we also had to observe the trends that are within our routine data, such as the health information systems, to monitor the impacts of the outbreak, but also the impact of our interventions. But also we are charged with the responsibility of looking at also the context, which was the changes that were brought about by those interventions. So once we had the question, we agreed on it as the IOA cell. And after that, we set terms of reference. Mainly that was developing objectives, But also the key point here was that from inception of developing these objectives, we engaged the users, the respective pillars. If a question was for case management, we engaged the case management committee or pillar from inception. We could develop the objectives, the concept together, and we set out to do the assessment when the user is already comfortable with a methodological approach. So then, okay, we developed the methods with the respective pillars or users. And after that, like any other scientific process, we validated our tools. But also we had to also observe concurrently what we were observing in our routine systems, the HMIS. Then now we analyzed our needs for data collection, and several partners were brought on board and other different specialities to support the assessment. We had a number of partners, as you can see here, like I had already presented. So we agreed on the results and we presented the results to the pillars, and we also co-developed the recommendation with the users or the respective pillars. But also we did not stop at just developing the recommendations. When these pillars received the recommendations, we developed what we call a tracker. This tracker is able to monitor the implementation of the agreed recommendations. So still how we operated in Uganda, like I previously said, we had so many recommendations, but we are not tracking how these recommendations were implemented. So we have set up a tracker to monitor the progress on our analytics for the outbreak, but also we are able to track the implementation of the recommendations that are developed from all the several analytics that we do. So the operations of the IOAs have been relatively smooth because of an already existing coordination and leadership mechanism within different response pillars. So before we adopted the cell, could you see that the different pillars had already a mechanism of working together. So, but also we have different experts within the Ministry of Health who are readily available for deployment. We also had developed a work plan initially at the inception of the cell, which guided the whole process. But of course, given the dynamic nature of outbreaks, we kept on adopting and revising the work plan. But at least we had a skeleton which was driving our operations. We also had a number of partners who provided support, technical, but also the financial support. So these are the areas that we think need strengthening and that are challenging for now, despite the positives that we have discussed. So some partners were not always readily available and their supporting mechanisms to Ministry of Health was not always clear. And here we require 100% dedication to the cell. If you say you are committed to the cell, we need 100% commitment. But also another challenge, although we adopted a rapid mechanism of having that, ensuring that all the proposals are immediately approved, which we did, there was a challenge working with the colleagues who were working remotely because the data sharing mechanisms across country was difficult, was not in place. So for colleagues who were already in the country, we had memorandums of understanding between our country and their organizations, and it was clear to work with them physically and share all the data sets, but it was difficult to work with colleagues who were remotely. Sharing data sets across was difficult because of the data sharing concerns. But also the financial mechanisms of ensuring that we pay our data collectors or the supervisors immediately is still challenging. And all of you are familiar with the bureaucratic financial mechanisms of governments. So we need a quicker mechanism of transmitting these funds to all the field officers so that we can have a smooth operation. So this is a snapshot. I'll not go through it, but this is a snapshot of our TORs. So the questions that we developed, we would move ahead of the outbreak. We developed questions from several data sources. Then we would look at the data sets, where are the potential data sets that we are going to look at. But also, like what I had already said, that we would set up what we want to do, but then the dynamic nature of the outbreak would dictate that we have a change in some of the questions which we had drafted. So some of these we have been able to execute them, but also some remained, we did not go ahead because the outbreak changed and they are no longer a priority. So we should have that kind of flexibility that we have to move as the direction of the outbreak takes us. So like some of these, we have already worked on them. Okay, so now, sorry about that. So we now, what we think would be really improve on those challenges that we faced, but also improve on this, reinforce the sustainability of the IOA, that we need to build, focus on building the Ministry of Health analytical capacities, so that instead of having these challenges of sharing data across country, we would build our own capacities here so that we are able to do all these analytics and the modelings, and we don't have challenges sharing data across as a limiting factor for analysis. So like I had also said, we need to identify a funding structure. The funding structure that is the peak, that is quick and that is not affected by those bureaucratic mechanisms of government, that will ensure that we have rapid teams deployed and they are facilitated without having hitches there and there. But also within the Ministry of Health, we realized that we need permanent officers who are dedicated to this cell, that instead of having most of the officers of the Ministry of Health who already have terms of contracts for other priorities, that we need to have permanent officers recruited and dedicated to the cell. Thank you for listening. That is the end of my brief presentation. I'll hand over to my good colleague, Simone Tata. Over to you. Thank you.
Thanks very much, Dr. Andrew. Great presentation. So I will look in the, I see we have one comment in the chat, but I'll see, Jennifer, I don't know if you want to raise your hand and speak out loud, or if anybody else has questions, comments. We have a good chunk of time for a discussion today. Is it that there's no hands, no questions? Rufus, yes, go ahead.
Sorry for, you may have some noise on my background. I'm traveling, I'm in the car. Thank you so much, Doctor, for the presentation. It is quite insightful and we actually picked quite a lot. I just have two questions on the issue of consultative approach that you used for the to gathering information when you were designing the strategy and also the tools from the community. What was your entry point? And also the second question is on the feedback mechanism. How is the feedback mechanism going to be for the communities also? What will be the entry point for the feedback? Thank you.
Thank you. Dr. Andrew, do you want to take a couple of questions or do you want to take one at a time?
Simone, so you're the chair, you can guide. We can take
okay, we'll take a couple. We'll take Olivia as well, and then we'll let you respond. Go ahead, Olivia.
Thank you so much. Can you hear me okay?
Yeah.
Two quick questions. One was on the need to build analytic capacity, and I was curious if there are specific analytic needs, like specific disciplines that you are looking for analytic capacity and what they are. And then the second one was to do with tracking of impact, and there were three things on there, and this was simply that I missed the third thing on the tracking on that slide. So just to go back to how the tracker works. That's all. Thanks.
Thank you. Rachel, are you okay if we take those two and then we'll come to you?
Yeah, please do. One of mine was related anyways. Thanks.
Super, thanks. Dr. Andrew, over to you.
So thank you. So the first question was on the entry point for these assessments. So all the time we developed a research question and developed a concept. We presented it to the Director General. That is the protocol of operation that he wrote introductory letters, which were introducing the data collectors and their supervisors. And these letters were presented to the lowest, to all the structures that monitor or supervise the last point of data collection. If we are going to say a health facility, all these letters were presented to the directors of those hospitals. If it was within the community, then they would be presented to the political community leaders and they would endorse their assessments. Then depending on the kind of survey that was being conducted, the feedback, even the recommendations were co-developed with the community. So there was the full engagement of communities where it was necessary. So on the analytical capacities, specifically on the modelings, but also on the geospatial analysis. But depending on the question which is at hand, it would do. So it's difficult to first to would do some mapping on that. There was a question on tracking. May allow me go back to the. Okay, so the tracking, we are able to track progress on each of the projects that we agreed that we need to execute this. So we would give, say, I would give them, say, like 2 weeks. By the end of, we start 14 days. Within 14 days, each assessment should have been completed and results presented. So, and that was in the tracking process. We track the progress, the data collection, we track the progress on analytics, we track the progress on the presentation and the co-development of recommendations until the project is signed off. So that was the kind of tracking. But also, sorry if I mixed it up, they will also have a tracking tool, which we call the monitor. This one actually tracks the implementation of the recommendations by the different partners. This is a long term. That is all on the tracking. Thank you. I hope I've answered you. If not, then you can. Okay, thank you. Over to you, Simon.
Thank you. Okay, so next we have Rachel and then Julia.
Yeah, thank you very much. I mean, my first question was also on the feedback, so you answered some of that already. The second question was, you mentioned some of the challenges in terms of data exchange when working with external partners not in the country. But I'm wondering if there's also some good examples you could just share of data exchange in the country that worked well to improve the analysis in this process, and what were the mechanics and how were those partnerships set up in a way that made that relationship work well? Thanks.
So when we set up the cell, being the first time we are setting up the cell, there are challenges which we learn throughout during the operation. So previously, we did not have an experience of working with the colleagues remotely. So you have dedicated officers who are in the country. They say like how our colleague Simon was in the country, and the mechanism of the terms of reference are very clear to the government, which has allowed her into the institution. So that there is an implied mechanism of operation, which is clear. So we know them, yes, they are officers, they are here to support on that, and they are memorandum of the understanding between Ministry of Health and these institutions. However, so when we added the colleagues who were remotely, and we had no formal mechanisms of working with them, we had the challenges sharing data with them. Otherwise, for the in-country colleagues who are here in the country, we never had any challenge sharing with them data. We actually did the analysis together and we had no challenge with data sharing. Thank you.
Thanks, Andrew. And Julia?
Hello, yes, thank you for the presentation. It's very interesting and it's such an impressive collaboration. Really, really exciting to see all of this. My comment and question is, I'm with US CDC and we have, our collaboration is very much structured around emergencies. So we come and help when there's an emergency, and when cases become lower and hopefully we won't see any new cases, then our support and our participation gets reduced, and to the point where we then go on to helping with another emergency in another place. That's not very helpful for supporting the development of these structures and having structures ready for the next time there's an outbreak. And I'm just wondering if you have any thoughts, Dr. Andrew, about how we might transfer some of this to a preparedness framework, or think about ways to continue to be connected when emergencies are over, so that we'll be more ready with what we need to put together quickly when another emergency comes. Thank you.
Do you want to go ahead and answer that one first, Dr. Andrew?
Thank you for that question, which I think is actually like a recommendation. And it is indeed true. So some of the analytics, so if you can see the outbreak of Uganda, very soon we may announce end of the outbreak. And some of the achievements which we have made during this might go away. But what we need is to think about how we can continue to do this, how we can sustain this. So on our side, what we have done, we interested this concept with the Ministry of Health leadership, and we are actually thinking that on the way of how we can operationalize this, not only be activated during outbreaks, but also remains a structure within the Ministry of Health. We have different technical working groups, and we are thinking of operationalizing this. Even when we do not have outbreaks, we continue to have this integrated analytics. So it has been adopted by some of the Ministry of Health leadership. We now have to continue with the consultative process to seek more guidance on how we can sustain this, since it already has a green light from the political leadership, and I think which is the most important here. So how we can work, so we already have colleagues who are in the country, like CDC, US CDC, if they can get more involved, because at least for them, they are already familiar with the political landscapes here. We are able to go through some of these political hiccups together. They are already familiar with them. So within the in-country institutions, if they can have their dedicated officers in there, and we work together and see how we can have this sustained, it will be very helpful. That is our thinking and the direction we are taking now. Thank you.
Thanks. We have another question, Ruby.
Hi, thanks. Thanks, Dr. Andrew. That's an excellent presentation. I was wondering, what types of questions did you receive and how are you able to answer them? Just a couple of examples would be great.
we don't have another hand up, so I don't know if you want to take that one first.
Okay, thank you. So we have actually we have a nice presentation on that, and we also have links, Google links, which are open, and we can be able to follow them up. Simone will share later. So like what we said initially, everything we did was informed by the existing situation. So we observed that there were nosocomial infections among nosocomial infections. Those are infections among health workers. So our concern, and this was occurring in specific facilities, not all of them. So our question was, why are we observing these infections among health workers? So we set up surveys to go and establish what are the existing capacities in those facilities related to infection prevention and control, but also the behaviors of health workers in those facilities. So we had a number of issues that were identified there, and we co-developed the recommendations with the infection prevention and pillar committee of the response, and we are able to address some of the challenges that were existing. We also had, we observed that we are observing abortions and other maternal related challenges in the communities. Yeah, so we are asking ourselves what is happening. Is it the disruption in service delivery that we have reprioritized our service delivery to the Ebola response, or is it that people are not able to access care, mothers and children specifically because of our lockdowns that we employed? So we are able to also conduct a survey that highlighted a number of maternal and child health issues that were related to access and utilization of maternal and child health services, and these have also been presented to the continuity of essential services pillar. Oh, thank you, Simone, for that. So I don't know if you are able to see the screen. This is what we have so far done. So like I've said, we did an IPC assessment, infection prevention and control assessment, but we also did an assessment on the maternal and child health. So we also have assessments that are in the pipeline. We did observe during outbreak that there are a number of community deaths that were reported. These deaths occurred within the communities. And these deaths were identified and they tested negative for Ebola. So the question was, why did these people die from their communities, and what are they dying? What is killing them? So we have set up, we are setting up first. The concepts are already ready. The teams, we are here to train the team, and we do rapid mortality audits to find out what was killing these people. We are wondering if it was another outbreak or if there was actually a service, why, or if they were not able to access services. That is a highlight of what we've so far done. We've also done routine. On top of these surveys, we're also doing routine analysis, the situation reports, and all these are, they have automated the processes in the other programs. So that's what we've done so far. That in brief, but we've done a lot more work than we could share in these few minutes dedicated to this. Thank you.
Thank you. I see Marie-Emily also has her hand up.
Hi, I hope you can hear me. So thank you so much, Dr. Andrew. It's really interesting. I wanted to come back a little bit to the conversation before about the sustainability of this IOA cell. And as you probably know, because you worked with Simone, one of the ideas of the IOA partnership is also to encourage country-to-country support and to leverage the domestic capabilities and capacities. So I was wondering, what's your vision for Uganda in terms of domestic capacities, not only our international organizations, obviously, I know, I think Makerere University contributed also to the cell, and also maybe in terms of collaboration with, regional collaboration with neighboring countries.
Thank you. Shall we take Olivier's hand as well? And then you could take both. To Olivier.
Hi everyone. Thanks, Andrew, for a nice and very clear presentation. My question is actually along the lines of Marie-Emilie's in terms of ways forward and sustainability. Andrew, you mentioned some of the needs to strengthen data analytics in country and sort of ways to do that. What's your sort of view on, are there other skill sets that are required or where there's gaps in needs and how to sort of address them going forward, thinking particularly on the social science side, which I think is a strength of the IOA Cell as well, to bring together different types of expertise and how that could be strengthened moving forward. And then my other question is essentially going back to your problem statement. You mentioned three things at the start of your talk. One was experts working in silos. The second was that data collection was not appropriate for use, and then the monitoring of recommendations. Can you say a little bit more about the data collection part, and whether that's something that the cell has been able to tackle in some ways, or what the plans are for that moving forward, and also what exactly is meant by data collection that was not appropriate for use. I guess there have been many challenges, I'm sure, with data collection on the ground, but if you could say a little bit more about that. Thanks.
Thanks both. Dr. Andrew, over to you.
Thank you for those questions. One was asking how do we see the cell, mainly the sustainability. So like how we said, this concept was welcomed by the political leadership, the leadership of the Minister of Health, and they have already, like I've already said, they have already agreed that we set up a mechanism to operationalize this analytical committee so that it functions even within, out of the outbreak setting, so that we would also not wait for outbreaks and to activate ourselves, but we should be part of the preparedness. We set up mechanisms of establishing the epidemic thresholds, and we have all these alert mechanisms in place from the analytical perspective, so that we are able to inform the move ahead of the outbreaks, and they find us when they are prepared. So instead of just providing analytics for the outbreak, we should be part of the preparedness, and that's what we are now working on, making sure that even when the outbreak is done, we are able to be on our foot, to be able to do analytics that will show, we will be able to detect or any outbreaks that are pending. The question on the partners working in silos previously and the data collection processes, but also in the dissemination. So previously, so like I told you, the CDP, the Strategic Information Research and Innovation, is a pillar or a subcommittee of the National Task Force and is charged with the mandate of data management and setting up all those other the systems. So what the challenge was that previously pillars or different partners would you develop the question, you go to the field and start collecting data, but it has not been scrutinized. And therefore it gives an opportunity for inappropriate approaches to be deployed if you are not under scrutiny. Yeah, because even any expert at least needs a review and a critique. But as the IOA Cell, beyond even that other kind of collaboration with the data users or the respective pillars which we deployed, we were able to look at this in using all the other experts that were on board. We had the social scientists, I am a medical epidemiologist, but we had an opportunity to share with the social scientists, all those other experts, all rounded experts, and we are able to look at deploying methodologies that are holistic, so that in case, so for example, if there was another example, like I say, we are observing case fatalities among children, a pillar would be interested, the case management pillar, for example, if they set out to do that assessment, their focus will be mainly at the facility level. They want to know why are we having these mortalities in this age group. For them, they will focus on the health setting. But when we are in a cell, in this IOA, the methodology that we apply, we don't look at only one center, one point. We are able to look at all, even the surveillance side, the community side, holistically. So the methodological approach is mainly holistic. That's what was a gain for this cell mainly. Thank you. I hope I've responded to you, Olivia. Over to you, Simon.
Thanks. And I see Ida has also put in the chat an important point about making sure that as part of institutionalizing the approach, that it's included in SOPs for outbreak preparedness and response within the EOC, and that could be helpful. So that's also something for us to think about in the coming months for cholera, for other outbreaks as well. Thanks, Ida. That's a great point. I don't know if there are any other questions, just checking. I hope I haven't missed anything in the chat. If I have, please do raise your hand. Just checking if there's any other hands. I know that we do have other colleagues who are in country on the call, so of course also you are welcome to speak and to share. Ruby, yes, go ahead.
Yeah, I just wanted to ask about this ambition of being able to incorporate community into decision-making regarding data collection and decision-making. And I was wondering if you've managed to achieve that here.
Andrew, do you want to go ahead?
Okay, thank you. So that one, it depends, really depends on the kind of survey or the question that you are dealing with, and it may be impossible to execute some surveys without having the community. So currently, on this study of the assessment of community mortalities using verbal autopsies, we've incorporated the mechanism of working with the communities. And so, because the deaths are occurring in the communities have the local leadership. They have the local leadership that certifies the burials before they take place. Although these are not legal, but the communities have their local structures which they have established, although they are not formal So we utilize this, we are planning to utilize these mechanisms to be able to conduct all these household surveys. And before, of course, like ethically and professionally, it is important that we share these findings with the communities, and we have put mechanism in place that before you exit the community, if you have had any engagement with the community, you share your findings with the communities. And if during assessment, you don't also just do the assessment and go away. There are some public health actions that you could do in the community before you exit. So if you are in the community, you are health workers, you should have, it's an opportunity to also share with them the information that may currently be needed. For example, like sensitizations on the current issues like the Ebola. So as we engage the community, we also explore these opportunities for us to deploy the public health actions. But the level of engagement with the communities largely depends on the type of the survey that we are working on. And yes, we have the mechanisms of working with the communities, and we have enjoyed a good working relationship with the communities. Thank you. Over.
Thanks again, Dr. Andrew. Okay, so let me just check if they're just reading in the chat. So some congratulations and great work to you and to the team. And I think that's it. I don't see other hands. I mean, maybe Dr. Andrew, if I may say, just I know that here we have presented some examples of a lot of the data collected to answer the kind of trigger question, but that of course we have also received as part of the cell, as Dr. Andrew did say as well, this real strong investment in improved routine analysis, which allows us to have those kinds of trigger questions, and that is equally a key part of the IOA cell. So, and that it has been this really strong collaborative effort. So I don't see any other questions. Dr. Andrew, I don't know if you wanted to say a last word or comments.
Thank you, Simone, and the colleagues for joining this call. We are delighted that we had this opportunity to establish this IOA concept in Uganda. We've had a number of challenges, but the opportunities and the achievements have been great, and we thank you, Simone, for being very vibrant and very resourceful. We hope that this kind of network will continue. Thank you, and over to you.
Thank you. And we're a big network, and we're really here to support you. So thanks very much, and thanks everyone. I think just maybe one last housekeeping point. I think this is the last call. Ruby, correct me if I'm wrong. This is the last call before Christmas, between the winter holidays, and we will pick up next year. We'll make sure that everybody has invites in the calendars starting in January again. I think we've got a full agenda booked up until June for the call. So thank you again, Dr. Andrew, and thank you to the entire team working with you on the cell. And we look forward to seeing everyone in the new year. Take care.